the space?
Same, Dave. So you guys go ahead.
Sure, thanks. We'll kick off then. I think I'll make it sort of nudging 12:04. For colleagues that are on the call, we've got about 24, 25 slides. So there's quite a lot to rattle through. We're going to try and work to sort of 30, 35 minutes, cover it off. Some of them, the slides were just for information. We probably won't talk, we'll just show them a little bit. So we're trying not to give you death by PowerPoint. We'll try and make it as informative and as interactive as we can. So if colleagues are happy, let's make a bit of a start. So I guess I'll talk to the first page. So you've got two faces clearly on the call today. Myself, Dave Smith. I'm the ICS Digital Programme Director and Acting CTO, Shared Care Record SRO as well, and joined here, as you probably gathered, by my colleague Anthony Gorman. Just to do a little bit of scene setting, actually, we commissioned a bit of work to maybe just use it to socialise the context of the shared CAD record that could sort of be, pushed out to improve communications. And if colleagues don't mind, it's only about 3.5 minutes. We wouldn't mind just playing that to you, just to provide a bit of context. So, Ant, if you could do the honours.
Each one of us is passionate about patient care. It's what we do, day in, day out. We are aware that patient care is complex. Over time, a patient may receive different forms of care from different care providers. Collating an entire care history for a patient can be a time-consuming process, leading to wasted appointments and frustrating delays for both the care providers and the patient. So, in 2016, we introduced our Care Portal to make it easier and more efficient for healthcare professionals to access data. The Care Portal is a free, secure online system, which is accessed through your web browser. It brings together patient information from across multiple clinical systems and services. Access is quick and easy with just one login and one patient search, giving access to summary care records and care plans, letters and appointments, allergies and medications, diagnoses, procedures and test results, and there is new information being added all the time. Already, the Care Portal has delivered over 20.9 million laboratory results, kept track of 6.8 million appointments, and kept record of over 5.1 million diagnoses. By bringing data and records together from all sources, Care Portal saves valuable time. Prior to Care Portal, patients may have needed a series of unnecessary appointments and consultations because of the difficulties that healthcare providers face when trying to share test results. With the emergence of the Care Portal, there is now an earlier intervention to patient treatment, as a large proportion of patient information can be viewed across all healthcare sectors. And the Care Portal now allows you to contribute to a single shared care plan for your patients. Patient shared care records allow clinicians to work together to build a joined-up care plan. To date, over 2,000 care plans have been added to patients' records using the Care Portal. We're working to make the Care Portal more integrated, such as adding more data and developing clinical alerts and analytics capabilities to make it more useful to you, the clinicians. And we're working towards introducing a patient portal, allowing patients the ability to see their records and contribute to their own What Matters to Me care plan. With the Care Portal, we are able to provide better and more informed care to more people across our community. If you're already using the Care Portal, we'd love your feedback. And remember, the service is free to access. Contact our digital team to see firsthand how it can benefit you and your patients.
So thanks for playing that out. Hopefully that's just provided a bit of context. We'll probably just cover a little bit of history, but I really want to obviously clearly get into what actually is on the system, what you can do with it as quickly as possible, so colleagues on this call can perhaps understand hopefully the value and the benefits that it potentially can bring to you. So next slide please, Ant. So a little bit of a summary in terms of, I guess, our journey. So as I think we've indicated there, programme was started in 2016 in response to a bit of an initiative around the Lincolnshire Shared Services Review. And if you want to rattle through some of these points, that would be great. And I'll just speak to them as the page fills up. I think the LSSR document, for those of us that have been around long enough, I think that was really in response to sort of dark days at the time when the county was deemed to be in a little bit of a mess financially, and had basically written out to engage all services, including the local authority, to say what do we need to do to improve our system. And it was across all sort of spectrum, both sort of acute medicine, surgery, planned care, unplanned care, both social care, mental health and community, and digital as one of the enablers was clearly pulled into that exercise. And at the time, I think the overriding priority that came out of digital was to provide a system, ideally a single system that clinicians could use rather than having to log into multiple separate systems like pathology, pharmacy and radiology, etc., to improve efficiency. So that was really the concept behind the programme. It was funded, rightly or wrongly, initially through Primary Care Estates and Technology Transformation Funding, our legacy CCG SRO for digital. Gary James took that decision in terms of biggest bang for his buck. There was a small team. I guess I was number one. We did expand a little bit out to 4. But currently there's just the 2 of us, myself and Anthony, so quite a challenge to keep the programme moving forward. In terms of trying to sort of fly the flag for Lincolnshire nationally, as part of the programme, we've been first of type with NHS Digital around actually integrating to the Summary Care Spine Service, the Child Protection Information Spine Service, and actually GP Connect, I think, was a bit of a game changer for us when COVID hit, in terms of patients being admitted into an acute care setting and our acute clinicians, our acute colleagues being able to see to some degree for the first time in real time medications and allergies and the full patient record. But I can cover that for you in the webinar, hopefully, for those of you that aren't already aware. We've had to meet some targets from NHS Digital that were set last year for something called Minimum Viable Product version 1. We did that, and we've also managed to connect to some out-of-area organisations, North West Anglia Foundation Trust in particular, in response to demands, requests from our GP community in the south to say one of the things that's really hurting us is not being able to see referrals and appointments and encounters in Peterborough. So we addressed that, and I'm pleased to say we went live with that. I think it was around about November last year. And again, if you're not aware, that'll come out in the webinar. And then NHSD also set targets around those sort of areas there that are detailed, to say we want your shared care records to integrate with social care, which we've done, care homes, which we've done to some degree, we'll cover that, and also encouraging us to look at care planning. And there's also a little bit of a push towards analytics as well. So that's the context, that's the summary, and perhaps some of the ticks that we've done nationally. This table is just designed to provide a bit of a summary in terms of the information that we're currently getting from our respective provider organisations. So I'm not going to sit here today and go through those. I'll let colleagues have a look at that if they choose to do so off the back of the presentation when we push it out. Clearly, from my perspective at least, we're looking to try and augment that as much as we can. I'm conscious at the moment that there's a bit of a weakness in terms of we haven't got any information really other than lab results flowing out of North Lincs and Goole in the same way that we have from NWAFT. So that is recognised, and we'd like to take that forward as part of our programme, but it all comes down to capacity to some degree and priorities. And equally, we'd be looking for feedback really into the ICS clinical reference group to try and help set some of these priorities. But I do feel as though over the last couple of years, especially with COVID kicking in to some degree, just because of all the challenges, we've been putting ideas forward, we've been doing work, not necessarily been in a position to go out and consult. I'd like to think we've exercised some common sense in terms of the decisions that we've made, but it would be really useful for colleagues to get involved with the clinical reference group and to perhaps provide a bit of a steer in terms of what the priorities are for the system. Next slide, please, Ant. So I'm not going to go through these. This was just, I suppose, to try and socialise that we have challenges to move things forward. In terms of the shared code record, there are certain constraints we have to operate with. So, for example, the GP Connect Spine mini service doesn't support what we call a persisted message transfer. We can't grab data out. We can display it, which is great, but we can't get data out, which is a bit of a frustration from my point of view, because it would really be helpful in terms of analytics and maybe to support population health management going forward. So we're looking at alternatives to how we can address those sort of things. We're pushing the centre to say, how, can they help us out? How do we crack maybe accessing things like Apple and Google, the ecosystem? We don't really want to be doing it as all 44 ICSs in England, do we? Can they not step up to the plate and provide a bit of resource and capacity to try and help deal with that, rather than us trying being the operative word to deal with it all locally? We've been first of type, as I've said, around a number of things. Certainly GP Connect, we were nationally for what they call structured data. We'll show you that. And we were for Child Protection Information Services as well. We're currently working on with NHSD in relation to NHS login for patient portal. I'll touch that a little bit later on. And then some of the non-technical stuff that, again, you can see there that we sort of battle with a little bit in terms of some of the technical integrations, depending on some of the suppliers. Their maturity can be quite challenging. We're conscious that from our point of view, we really want to push third sector integration. It's not a technical issue from our point of view, it's an IG issue. And we just need help and support to move that agenda forward. And then equally, trying to adopt and support some of the best practice standards from organisations such as the PRSB. Funding, to some degree, has been a problem, is a problem for us in terms of the whole programme has been hitherto funded on non-recurrent, capital. We don't get any recurrent revenue, which causes a few challenges, which I'm sure colleagues will understand and resonate in other areas as well. So that's just to set a bit of context in terms of what myself and Anthony are battling with us a little bit as we try and move things forward. Next slide, Anne. Big busy diagram, this one. Not going to jump through it all, but what it's trying to show, I guess, along the bottom is we can link into all sorts of source systems, as we refer to them. So pathology, radiology, pharmacy systems within an acute trust. Mental health trust, ambulance. The idea there is to try and sort of show that we have the potential to connect using the shared code record into these environments. I think our mantra is, if it's held electronically in a file, we can probably do something with it. It's just a question of how hard is it and what's the cost to deal with it. The bulk of that diagram in terms of the webinar today is what we're looking to sort of communicate today is very much around the professional view, but it's really to point out that we do have a module, albeit it's a bit immature. We've hit a few problems. We've picked maternity in the context of a patient portal, so the patient view that you can see in Salmon, and then COVID's hit, and then we've lost the project manager, so we're struggling to move that forward a little bit. We do have care planning capability, and Anthony will socialise that on the call today, and we do have the potential to do some really clever and some really interesting developments around real-time analytics. So we've done an art of the possible demonstrator that we're trying to socialise across our system in terms of what we're able to do in that space to support urgent and emergency care. We started to socialise that to CNIOs at LCHS and ULHT, but would welcome the opportunity, perhaps another event, another webinar to illustrate what potentially we can do in that space. Myself and Anthony are due to meet the ICB Clinical Directorate to also do a bit of a show and tell with them sometime next month, and we're hoping to cover that as well. But that just gives a little bit of an overview in terms of what the system is. So we had clinical viewer, patient portal capability, care plans, and then potentially analytics. Moving on then in terms of what does it mean for your good self, let's get into the nitty gritty of it. So for those of you that aren't familiar with it, the system, the clinical viewer, this is basically what you'd see when you do a patient search. So you do a search for Dave Smith, this would sort of land on your main page. And what this is showing is basically the sort of categories of information down the left-hand side. And where there's a green bar, that's indicating that it's in real time when you've done that search, it's gone out and queried those source systems or organisational repositories that we have across the bottom of that previous slide to say, actually, have we got any data that relates to patient X that we can display? There's no green bar there. It means we haven't got any data for whatever reason. There just isn't any available. They haven't had that contact with I don't know, mental health. There is no mental health record, if that makes sense. So that's just really trying to set the context. Next slide, Ant. I wanted to talk a little bit as we start to go through each of those categories, really give you some examples of the type of data that's in there. So we have mentioned the GP Connect. So again, GP Connect National Spine Service. And this is what we're using currently to surface primary care data in the shared care record. This is a direct lift off the NHS digital website to say this is the information that the GP Connect National Spine Service provides. The headings there are clearly the ones in bold. And just to call out, there are two aspects to GP Connect. There's what they call the structured data and the unstructured data, and we'll just quickly cover those now. So again, so the screenshot here, if we'd have clicked on the medications tab on the left-hand side, this is actually giving you an example of how structured data can be pulled through. The aspiration there is that as we work to integrate other EPMA systems, and work has started with ULHT, so think of it in the context of medicines reconciliation. We're looking to integrate to ULHT's EPMA system, their medical pharmacy administration system. So any information they've got, we're thinking of TTOs to take out ordered drugs, would appear here. So you'd see it on a consolidated page. The same applies through to mental health. We're aware they've got an EPMA system for mental health, and we're planning to integrate LPFT's EPMA system as well to try and get all that information in the one space. So that's an example of structured data. Some of you may or may not be aware, though, the other part of GP Connect is the unstructured data. So this is all those headings that you saw on that previous summary. This gives us access to that other data, but not in a structured way that you've just seen for medications. And the way you do it is by going into the Documents tab, as you can see on the left-hand side. You'd select that GP record. That GP record should always be at the top in the document section, and then it opens up effectively, it's like summary care record on steroids, effectively the primary care record. And this function works for both EMIS and TPP practices. So if you've got mixed economy PCNs, potentially we'd like to think it's quite useful. We'll just give a couple of screenshot examples of that. So next slide, please. And so here, hopefully you get the idea. It's starting off in summary. It's presented as an HTML file. You can see at the bottom there, it starts to run into the encounters. And then if we go on to the next page, again, it's just a scroll down example there. You can see the active problems, issues, and etc. So not jumping back on this screen, but if you refer back at your leisure at that summary table that was listed with those black headings, all of those sections, if we were to scroll down this in its entirety, would feature as part of the GP Connect integration work that's being done. Thank you. And next slide, please. I think this is the one for you.
Yeah, give you a break from talking, Dave. And as Dave explained, when you go into each one of those tabs that you can highlight, you can see that there's information present. And if we just sort of go through some of those, just to give you an idea of what sort of data can be seen. This one, for example, is the type of documents that we can see. As you can see to the left-hand side, we've got all 3 trusts have got data visible. So we get data from LPFT, from ULHT and from LCHS. But as you can see in this example, we've also got a document from EMAS where the patient at some stage has had an ambulance encounter. You can click on that ambulance patient summary document title there, and it will open up the ambulance summary report, very detailed, what the paramedics complete. And the same here for this one, this system 1, the palliative care summary. This is where we've recently introduced the EPACS information that's collated out through primary care. And you can see the responses to that EPACS summary. And I think just to give you an idea of volumetrics, we've got approximately 20,000 EPACS palliative care summaries now present in the care portal. And this just shows you that, again, some of the information from LPFT could be care plans, CPA records, and also we get the clinician letters, the general letters from ULHT. This one, again, this just gives you an idea that social care is now presented in the care portal. Again, this is a relatively recently new addition that we had. When you click on that social care tab, if that patient has got a social care history, you will see some details, and then each one of these is almost like a tab within tabs. So if you click on there, the address details or the assessment details right the way through, it will present the information available. This is an example of the encounters. So again, here you can see we've got all 3 trusts, plus we've got the EMAS information. You can see here that this patient was conveyed to Boston Pilgrim with abdominal pain. And if you wanted to look at the detailed report, you would go back into the documents, click on the ambulance summary report, and you would see that information. The same for any referrals. Again, we've got referrals now from LPFT, LCHS and ULHT. So we capture that key information. And the same here with the appointments. You can see any scheduled appointments, any past appointments, and you can see again where they were held, what source information, and you can see some details around those appointments. And they get refreshed once that appointment gets attended. The last one, again, is this one for me, Dave, or is this one that you wanted to sort of elaborate on?
I'll cover that one if I may. And just jumping back a little bit, though, those screens that Ant's covered, just to add, for each of those categories for referrals, appointments and encounters, we've also got information feeding through from NWAFT. So, for all that activity, where any patients that have been referred into Peterborough, Stamford or Hitchingbrook, then potentially we get that information out of NWAFT, and that also extends through from their PAS for procedural information and diagnosis information as well. Jumping onto this particular tab, I just wanted to sort of call it out because some people may or may not be aware. Again, when you log on to the Shared Code Record Eye Care portal, you search for a patient, you have to claim a relationship, dare I say, to keep the IG police happy, and rightly so in terms of Caldicott. By virtue of the fact you've claimed that relationship, then what the system does is it automatically adds you into the care team, because the idea here is it's trying to build up dynamically a real-time view of those clinicians that have interacted with that patient, and the concept being, rather than trying to phone up, Dave Smith admitted to Lincoln County Hospital, under, who, to what degree can I speak to a clinician, under whose care, he is. This is really trying to sort of assist with providing staff with an at-a-glance view to see who's had contact with that patient recently, and providing both email addresses and contact phone numbers, so you're not having to go through switchboard, you're not trying to find out necessarily, through the push through the mud, so to speak, to find out who's been in contact with that patient and is involved with that patient's care. So that's the intention of this, of what this tab's providing, if you're not aware. And the relationships are maintained for 12 months, and then you have to sort of reclaim them, if that makes sense. This is another one moving on in terms of those categories of information there on the left-hand side. Again, this is a recent addition, given that we've completed the integration work with LPFT. And for those colleagues that weren't aware, this is now providing, you know, that mental health assessment status. Again, it's all real time, bang up to date. So if you weren't aware, just really to sort of socialise that. Thank you. Next slide. Observations. I think I'm probably talking to this one. Again, just to point out that as part of some work that was done, gosh, probably a bit pre-COVID, we were doing a bit of a pilot with the Wizan system, having that deployed into care homes. So all of our care homes have got the ability to access Wizan. And as part of that work, we took a decision to effectively provide an integration. So any observational data that's captured within Wizan from the care homes, we get that real time fed out into the shared care record. And that's just an example of that. Where we'd like to go, we've currently got some work in training with ULHTs. They have a system called ECOBS, Electronic Charts and Observations. And we're looking at trying to grab the same data set out of ULHT. I guess the logic there, to some degree, was you've got a patient that in a care home, for whatever reason, has had to be admitted into acute. If we can get the same observational data out, then if they hopefully successfully get discharged back into the care home, be able to see that history, and then potentially we could do some clever stuff with analytics going forward to say, actually, look, all the blood pressures started to deteriorate, or respiratory readings have gone down. Can we alert to see if somebody can go and take a look at the patient to see if we can avoid a readmission? So that's the sort of thing in terms of that we'd like to contemplate and be looking at going forward. Next slide. Thanks, Anne. Another one from me. Again, for those of you that perhaps aren't aware, maybe don't look at it for whatever reason. If you can see on the top right there, there's a little green bar under the heading called subscriptions. This hasn't really changed much since the system was commissioned and built. And the intention here is you can click on each one of those three categories. And what it means is for all those patients that you've done a search on, that you've claimed a relationship with, you get a notification to say if a patient has been admitted and patient discharged. And that's clearly selectable by individuals on a user by user basis. So if you're not aware, that's what that's intended to do. And it would manifest itself as if you were to select that, depending on what email address you've registered on the shared code record, whether it's your NHS mail or maybe another email address of some description. I would imagine it to be an NHS mail for primary care. In the event that you had a patient that you had a relationship with, and let's say it was an emergency admission, you would get an email in your inbox, your NHS mail inbox. It's quite anonymous, so it doesn't contain patient identifiable information as such, to say emergency admission, click this link, and it would effectively launch the care portal and take you to that patient so you could see who it was. So that's what that's designed to do. We've had a bit of interest recently from a couple of services. I think maternity are interested in seeing what we can do to potentially exploit this capability to help communicate out to community health nurses when one of their patient under their care has been admitted to maternity, to provide notifications out to community health. And we're also looking at this in the context of palliative care. I think off the back of the work that's been done to integrate the palliative care information, there's an example whereby if a patient's admitted to hospital and we can see they have a palliative care plan, to what degree can we alert staff out, perhaps on the ward and or to others, to say you need to look at the fact that they have a care plan as part of supporting that patient going forward. So that's really what the what the intention is around there, and potentially just to socialise what our capability is. Next slide, please, Anne. I think
Okay,
this was
this
one
is
for you.
for me to take over, and a good there, Dave, that you mentioned care plan. So a great segue. So as you may be aware, for those that regularly use the care plan and use the care plan capability, it was something that we went live with around 2020, and it really came about through the personalisation programme and their personalised care and support plan. And what the system requested was that they wanted a single electronic solution that would allow staff, regardless of what setting they sat in, so whether they was in acute, in community or in primary care, that they could access a single shareable care plan. And part of it was to avoid having to repeat the same conversation and to send it across partner systems. I always recall when we moved the father-in-law up here due to his health conditions, and in one day, in the space of about 2 hours, we had 3 different care providers come in to see him, and they all asked the same questions, but in a different manner, and how they recorded them on paper, on a laptop, and almost like a predefined form. And he just was getting really tired of having the same conversation, especially in a space of 2 hours. And what the care portal does, it can facilitate this. We can build a care plan on behalf of the service. And at the moment, we've got 4 care plans that are live. So they define the content that they want, we build it. And what this does, it allows us to add a care plan to the patient's record. So if you clicked on the care plans tab and there was nothing in place, you would click on the add care plan, as you can see at the bottom here, and it would give you the care plans that are live, and you can add them. And it's almost a series of responses to a series of predefined questions where you're capturing that information. And the idea is once it's captured, you save that care plan on the system, but then others are able to not only see the information, but they could also contribute to that same single shared care plan. It can be published at any time, and it puts it in a published care plans tab on the system. It could be printed off if required, if the individual wanted a copy, but we do try to keep it electronically because we've got full version control. If you print off a PDF, you could lose the version control because somebody could go in the following day and make some changes. But the whole point of this, that it allows us to build and amend, care plans based on the service needs. And I think I said we've got the stroke, we've got the What Matters to Me plan, we've got the discharge or the SPA form that's used in acute, and we've got the stroke care plan. And again, I'll give you an idea of some of the volumetrics. The 2 sort of telephone dials that you can see in the centre of the screen, this is really just to show the reach of the care portal. At the moment, when care plans are added, and if they need to be contributed, whether people sit in primary care, they either work in a GP practice, or care coordinators work in the PCNs. They could be mental health assessors that work in LPFT. They could be adult social care that work on the wards up at the county and at Lincoln and at Pilgrim. Could be CCG staff. It could be LCHS, and of course it could be ULHT in acute. So all of those are able to access that single shared care plan. And if we compared it, for example, to System 1, we noticed that the reach isn't as great as what it would be if a care plan was on the care portal. We know that LCHS have access to System 1, but it's not the same as what the GPs use. And then as you can see there in red, there is no access, or there's no data sharing agreements for those to get access to those systems. So we're just saying here that the care portal does have quite a very good reach across the system. It covers all of our partner organisations, plus LCC, CCG, and of course we've got St Barnabas. And there is work going on in progress in the background. Dave already mentioned that we do, one of the challenges we have is some of the IG that we need to come up with the process around how care homes and other third sector organisations could get access to the care portal. When a care plan is on the care portal, it's fully auditable. You can see anyone who makes any contribution, and that could be whether they just change one word in the care plan or they completely rewrite it. You can go back and you can view any previous version that had been added, and you can also compare 2 versions side by side. And just to give you an idea of some of the volumetrics that we've got, the stroke care plan is definitely leading the way. You saw in the video that we said we've got over 2,000 care plans. We now have got almost 2,700. That's growing month on month. The personalised care and support plan, or the What Matters to Me plan, we're starting to see some, let's say, some increase in the numbers of those care plans that are being added and contributed to on the care portal. And really pleased to say that Morisco Practice, because I noticed Morisco is on this call today, they are really leading the charge. There's two of the guys in Morisco very active in adding the What Matters to Me plans. And I think of all the care plans that got added this month, I believe Morisco are responsible for about 80% of those. But we are seeing more PCN staff and primary care staff adding the What Matters to Me plans via the care portal. Last but not least, we have got e-learning available. So we have got 2 modules that you can access. You can either access when you click on the care portal, before you log in, you can click on the help screen. It opens up in a separate window, and you can then access the care plan module, but you can also go through the care portal e-learning, and that just shows you how to navigate through some of the tabs. The care planning, again, that gives you an idea of how you can add a care plan, edit, and some of the rules to be reminded of about making it active. And the care plans, hints, tips, and FAQs is trying to dispel some of the myths that we've had. And it's really was built on the back of taking user feedback. For example, care plan can be published at any point in time. It doesn't have to be marked as final before it's published. And then we find that really useful for the people. I'd always recommend to go through the hints, tips, and FAQs before you start adding the care plans, because it will just give you that broader information available. We have got a standalone site where you can access the care portal training. So there is 2 methods to get access to that e-learning. And finally, this one, we will share the slides afterwards. It's just a reminder for those who are either employed by the GP practice or the PCN, that if you've got a single point of contact, or you need more information, or you need to get access to the care portal, just go via your practice manager if you work in the GP practice, or via the PCN single point of contact. And that just here that just remind people about the role-based access controls, because some of our PCN care coordinators were given clinical admin, which means they can't see the care plans tab. So we got an agreement with the clinical reference group back in 2020, I believe, where if people do need have direct care responsibilities, they should be given a clinician admin, a clinician role-based access control role, which will enable them to, 1, see the care plans, and then they would be able to fully contribute to those care plans. So that's it. That's it from us. We're really open to take any questions from anyone.
Stunned silence.
Any questions from anyone on the audience?
Yeah. Feels like it's a hard no.
I think we'll take that as positive.
Well, I was going to say that's the epitome of a good presentation, isn't it?
I suppose, if I may, just to come in on that point, I mean, clearly we can't tick all the boxes necessarily for everybody, and not necessarily from day one. So I'd like to think that from what you've seen today, hopefully, if you weren't already aware, you are now, in terms of the sort of data that we've got in there. I mean, it is, I like to think it's pretty rich. It's clearly not totally comprehensive, but in terms of sort of 80-20 rule, I'd like to think that, certainly from my perspective, that for a lot of the practices, that information, the information that's currently there, would be useful. And clearly we've got a lot of data there from ULHT. We've reached out to social care, which hopefully is beneficial as well. Pulling in the community data and the mental health data, we'd like to think would be beneficial as well. The fact that we've reached out to NWAFT, and you can see all their referrals, appointments and encounters and their procedures and diagnosis. We've got work going on at the moment with NWAF to try and pull in their lab results, and ideally we would like to pull in their radiology results as well. And we're conscious we need to reciprocate that really for North Lincs and Goole. And then there is a number of in-flight integrations that I think I've touched on during the presentation that we're already sort of trying to take forward. We're trying to expand the lab results that are currently in the system because it's just ULHTs at the moment, so it's the whole health community, to try and reduce the need for unnecessary duplicate results. So we're conscious we want to expand that area in particular as quickly as we can. And then within ULHT at the moment, as I think I've alluded to, we've got integration work going on with their EPMA system. We have integration work going on with maternity to pull maternity documents in. We've got more stuff, integration work going on with cancer services. We've got another integration going on with cardiology for reports. We're expecting to land endoscopy reports in there shortly. So there's a raft of things that are going on. But I think if colleagues can just appreciate the fact that to some degree there's just me and there's just Ant, and each of those are projects, and actually what we're struggling for a little bit is capacity to move things forward. And in some respects, we really need our system to say, look, yeah, we need this sooner, perhaps to maybe make the case to try and pull in some extra resource, if that makes sense.
I'll put my hand up, Dave. It wasn't really a question I wanted to raise. It was just a reminder that if people are about to use the care plan capability and then they was in need of a quick demo, I'm more than happy to join any Teams calls they may have and run a demo of the care planning capability. I know we've got the e-learning there, but sometimes people have liked me to go through it and watch me sort of add and edit a care plan and show them how the audit capability works and how you can see the information on a published care plan. And like you said, not only have we got the 4 ones live, we've been approached by the transformation team. We're looking at Parkinson's disease, so we may have a specific care plan, and we know that the cardiac rehab team and the cancer team are also considering having a specific cancer stroke cardiac rehab care plan similar to what the stroke have done. And we can able to build that and add that to the care portal. So yeah, but if the demo is required, just reach out to me and I'll happily join a Teams call and run that demonstration for you.
Thank you. I think my last point just from me is, again, just to sort of restate, we're trying to set up a broad sort of clinical reference group. It's not just about the shared care record, but in a broader sense at an ICS level. We've had, I guess, the first reinvigorated meeting of that occurred last month. John Rouston, he's the CNIO for Lincolnshire Community Health Service, is taking on the role of chair for that. But we'd encourage colleagues that want to get involved in terms of what's important from a clinical point of view, what services need to be taken forward. To put the hand up, maybe reach out to John, potentially, myself and Ant, if people want to get involved with that group. Certainly, from my perspective, we're looking to that group to try and help steer some of the priorities that perhaps we need to respond to. So just a call out there if colleagues are interested to get in touch.
Brilliant. Thank you, David, and thank you, Anthony. I think this was really, really helpful. The recording will be shared with everyone, whether you were attending or not, so it's fine. And if there were, further events in the future with maybe gathered relevant updates in a couple of months about the care portal, we might organize another webinar, so that will be familiarized in due course. But if no one has any other questions or other points they would like to make, I think we can stop the recording and we can get almost 15 minutes back. So